continue to move on. These are really tricky curves. You have to be careful to first identify what are we looking at, what's on our axis, what are the values, and why are we even looking at this diagram. So we reach these cardiac and vascular function curves, which seem rather confusing because there's two variables on each axis. But remember that if we understand the conceptual physiology behind the heart's function, we can tackle any sort of diagram on the exam. So before I start, let's think about the term that is on the different plots that are listed on diagram A. What is meant by inotropy anyways? So, ino is Greek for fiber, and tropo is Greek for change. So changes in the inotropy reflect individual sarcomere fiber lengths of a myocyte changing in some way. Agents that increase inotropy can be considered in your mind as anything that increases intracellular calcium. Because remember, that's how we get more contractility and an increased frequency of contraction. Remember, you should always consider increased intracellular calcium in a myocyte as increased exposure of myosin binding sites on actin, therefore more contractions. So now, what about the diagram? What is this interaction here? So where the red line crosses the blue line is defined as the operating point of the heart. Now what does that even mean? It indicates where the venous return will equal the cardiac output. That makes a lot of sense, right? Because if the amount of blood that you pump into the arterial side should come back in the venous side. So this means that everything is working normally as you would expect. The cardiovascular system is just one big closed loop. Anything you pump forward as your cardiac output should eventually come back as your venous return. Otherwise, you would have pooling somewhere in the systemic or pulmonary vasculature. If you look at the curve labeled with a 1, which is here, this shift in this direction is due to catecholamines, or the sympathetic nervous system, and digoxin. Either one of those will cause this shift upward. Both of these are positive inotropic agents because they cause an increase in intracellular calcium, but they do so by different mechanisms. The main point is that you increase the contractility or inotropy of the heart, allowing a higher cardiac output. So as you can see here on our y-axis, cardiac output is definitely the value that we're trying to determine. If we give someone positive inotropic agents, we would anticipate an increase in our cardiac output. Under the influence of the sympathetic nervous system or digoxin, your heart will have an increased intrinsic ability to create more force. This will be directly reflected as an increase in stroke volume, which is a component of our cardiac output equation. Cardiac output equals heart rate times the stroke volume. So we're increasing our stroke volume, therefore increasing our cardiac output, therefore shifting this line nice and up the y-axis. And just like we said, the operating point of the heart is where the venous return equals the cardiac output. We're increasing our cardiac output, therefore we should increase our venous return because that blood will be returning to the right side of the heart. Remember that the sympathetic nervous system will increase the heart rate, and digoxin actually has a depressive effect on the AV node, so it can cause some bradycardia. But digoxin's main effect is increasing intracellular calcium by inhibiting the sodium-potassium ATPase on the basolateral membranes, therefore causing an increase in the ability to maintain higher levels of intracellular calcium, and that's how you get higher contraction. Now, let's observe the area where you see number 2. This is where someone got a negative inotropic agent. If a positive inotropic agent increases cardiac output, you would expect a negative inotropic agent to decrease cardiac output, probably by the opposite mechanism that positive inotropes work. Uncompensated heart failure and narcotic overdose are listed here. So, uncompensated congestive heart failure, or decompensated, and narcotics. Obviously, in decompensated congestive heart failure, that is defined as a decrease in ability to contract due to chronic beta-adrenergic stimulation and the slippery slope that happens when someone continuously activates their sympathetic nervous system, renin-angiotensin-aldosterone system, and the endothelial cell dysfunction that comes along with congestive heart failure. So at some point, eventually, they will progress to decompensated heart failure, where they have a decreased ability to contract, and that is defined as negative inotropy. In the case of narcotic overdose, you directly suppress some of the cardiopulmonary centers in the medulla that causes a severe decrease in heart rate, which makes your cardiac output drop, because the equation is cardiac output equals heart rate times stroke volume. So in this situation, we're decreasing our heart rate, and in this situation, we're decreasing our stroke volume. Either way, there's going to be a decrease in cardiac output, and that's why our curve shifts down. In summary, both have a decrease in the overall cardiac output, shifting your curve down. So again, positive inotropes shift our curve up, and that is green, and then negative inotropes, which is shown as the red arrow, shift our curve down. So let's go on to examine the venous return curve labeled B. This is a very important slide because it tests your ability to understand the different shifts related to the venous system. Venous return is determined by the pressure gradient that is determined by the equation. Venous return equals venous pressure minus the right atrial pressure. Anything that increases venous pressure here will obviously increase venous return because this will be a higher numerical value. This is just like the P1 minus the P2 different pressure gradients. There has to be a pressure gradient for blood to flow from the venous systemic circulation back into the right side of the heart, or the right atrium. In addition, anything that decreases right atrial pressure will increase the return of blood to the heart. A great example of this is when you take a deep inspiratory breath, you increase the negative intrathoracic pressure, causing a decrease in right atrial pressure, and this causes an increase in the vascular return of blood to the right side of the heart from the systemic circulation. So let's review number 3. So if you give someone a bolus of fluid, you would expect an increase in cardiac output, so we shift up the y-axis, and we also increase our end diastolic volume of the right atrium because we're increasing our intravascular volume because we're directly pushing fluid into their venous system. You increase the venous pressure by increasing the intravascular volume. So this is the situation where we're increasing venous pressure. So we're increasing the end diastolic volume of the right side of the heart. And this also leads to an increase in the end diastolic volume of the left side of the heart, which means that we get an increase in cardiac output. In a similar situation, the sympathetic nervous system will cause a vasoconstrictive effect, which means that we increase our venous tone. And an increase in venous tone means that we have an increase in venous pressure. Same effect happens. We get increased venous return, and then increased venous return equals an increased cardiac output because the right side of the heart connects with the left side of the heart. This is also why you see the shift in the mean systemic pressure. So the mean systemic pressure is a combination of the arterial and the venous pressure. So the pressure of the arterial blood and the pressure of the venous blood. Basically, what would the driving pressure be for a fluid movement if the heart wasn't beating, which is the difference between the arterial and venous pressure. So if you increase anything in option number 3 by shifting the vascular function curve, you automatically increase the mean systemic pressure, which is determined where this blue line intersects with the x-axis. Now, why is that the case? Because the mean systemic pressure is increased because we've increased the venous pressure. So if we increase venous pressure, we by therefore definition have to increase the mean systemic pressure. Now let's look at the opposite sides. So if we're decreasing our cardiac output and venous return by decreasing right atrial pressure and diastolic volume. So we have a shift down, which is right here by this nice big red arrow, and a great way to think about this is it's the opposite of what we just talked about. So we said a bolus of fluid, and the opposite of that is hemorrhage. So if they're bleeding, they're losing intravascular volume. This obviously will decrease venous pressure, then it leads to decrease venous return. There's just not enough volume to create enough pressure to create that gradient from the venous systemic circulation to the right atrium to get that gradient of flow returning blood back to the right side of the heart. So if hemorrhage is the opposite of bolus, then what's the opposite of the sympathetic nervous system? How about spinal anesthesia, where you actually block the sympathetic outflow tracts because sympathetic nervous system runs in the perivertebral ganglion, and if you have spinal anesthesia, you can block some of those nerves, leading to a decrease in alpha-1 mediated venous tone. This causes a shift in your vascular function curve down, and anytime, remember, mean systemic pressure is a function of arterial and venous pressure, so we are shifting our mean systemic pressure down. So let's move on to talk about the last slide, which is C, and this has a lot to do with total peripheral resistance. Remember that total peripheral resistance is due to the arterioles that feed systemic capillaries. So here's our capillary network, and here's the arteriole with a very small radius that opens up into that large capillary network. So these are the precapillary peripheral resistance arterioles, and that is what we're talking about when we mention total peripheral resistance. So obviously vasopressors will cause an increase in total peripheral resistance because we decrease the diameter of this vessel. So we just discussed how peripheral arterioles that precede the capillary beds are the greatest contributor to resistance in the systemic circulation. Before we can start exploring some of the changes that are occurring, let's consider the equation mean arterial pressure equals cardiac output times total peripheral resistance. So if you give someone epinephrine and you get this vasoconstrictive effect, you increase the total peripheral resistance and you decrease cardiac output by definition if you want your mean arterial pressure to stay the same. So if you want to maintain mean arterial pressure, you increase the total peripheral resistance, but you must have a equal shift downward in cardiac output if you want to maintain your mean arterial pressure within a certain value. Alright, now what about the situation of exercise or an arteriovenous shunt? Both of these decrease the total peripheral resistance and allow the heart to pump much more blood out because it is pushing against a lower resistance overall in the systemic circulation. Alright, now let's start with the total peripheral resistance arterioles. This is a very important diagram. And before we discuss it, we need to remember a little bit about those total peripheral resistance arterioles. So again, the total peripheral resistance arterioles are the small vessels that precede the large capillaries that are within organs. So this is our precapillary total peripheral resistance arterioles. Obviously, a vasopressor will cause an increase in total peripheral resistance by a vasoconstrictive effect on these arterioles. So you shift down due to a stimulation of vascular smooth muscle cells lining this total peripheral resistance arteriole to clamp down, decrease the radius, and we know from our equation about resistance that will greatly drive up the resistance, and that will decrease the ability of the heart to pump blood out, causing a decrease in cardiac output, which is expected. We have shifted down and lost that cardiac output. And this does not necessarily lead to any sort of change in right atrial pressure. As you can see, there's a slight shift, but nothing that is worthwhile for noticing. It is important to understand why this curve shifts down, and that is due to vasoconstrictive effects mediated by a vasopressive-like substance. So before we start exploring some of the changes that occur, let's think about an equation real quick. Mean arterial pressure equals cardiac output times the total peripheral resistance. So if you give someone a vasopressive substance like epinephrine, you will have an increase in vasoconstriction, hence an increase in the total peripheral resistance due to alpha-1 mediated vasoconstrictive effects on vascular smooth muscle cells. Now what's important to know is that if you increase total peripheral resistance, by definition, due to this equation, if you want to maintain mean arterial pressure within a certain range, you have to decrease your cardiac output. And that's exactly what we see happening. We increased our total peripheral resistance, and it shifted down our cardiac output. Now what about in the situation of exercise or an arteriovenous shunt? So with exercise, we increase our sympathetic nervous system, having an increased alpha-1 and beta-2 stimulatory effect. We know that alpha-1 causes vasoconstriction, while beta-2 causes vasodilation. The thing is that the vasodilation of muscular arterioles is much greater in exercise compared to the vasoconstrictive effect of alpha-1. So we get a net vasodilatory effect in exercise. Now what about the situation of an arteriovenous shunt? remember, arteriovenous shunt means that from the arterial circulation to the venous circulation, there's an abnormal connection where we bypass the total peripheral resistance arterioles completely. We just go straight from artery to vein. We bypass the precapillary arterioles. We bypass the precapillary resistance arterioles. We bypass the capillary circulation. We just go straight from artery to vein. And that means that we have a very, very low resistant circuit. Those are very large vessels, and the cardiac output will be an increase because, by definition, in our equation, mean arterial pressure equals cardiac output times total peripheral resistance. We have greatly decreased our total peripheral resistance by bypassing the precapillary resistance arterioles. Therefore, our cardiac output will skyrocket. And that's why having an arteriovenous shunt is dangerous, because you can lead to heart failure from chronic elevated levels of sympathetic stimulation because we have to maintain such a high cardiac output due to a very low total peripheral resistance.